Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome Joseph Parker. He's a research physician. Today's Kevin MD article is titled The Persecution of Pain Management Doctors. Joseph, welcome to the show.
Thank you very much. I appreciate the opportunity.
So let's start by briefly sharing your story and journey to where you are today.
I grew up in rural Arkansas, born in Kansas, but I grew up in rural Arkansas, joined the Marines out of high school to go to college, finished a degree in computer science, and switched to the Air Force. I was an ICBM commander for a while and then got accepted into medical school on an Air Force scholarship. And very blessed to get to go there and have practiced general and emergency medicine since.
All right. So tell us your interest in pain management. I know you've written several Kevin MD articles, so tell us about your interest in that.
Pain, as an emergency doctor, you see pain all the time. You know, half the people who come into the emergency room come in there for pain. And not all of them have acute pain. Some of them have severe chronic pain and they're traveling or something has happened and they're running low on medications. And so our doctors had been trained to be pretty harsh on people coming in for pain so that we could be observant and make sure that we didn't overprescribe. At the same time, as I was doing general medicine, I became aware of the fact that people with severe chronic pain are stuck in a horrible situation because they have nowhere to go but the ER if something goes wrong, and then they are treated horribly. So I started to I started kind of adjusting the way I approached pain when I started working with a pain specialist, and I would handle the general practice issues that they had, and I got to learn a lot by working with her.
So tell us what you learned. So tell us how that philosophy towards pain changed from that ER mentality. But once you got that perspective from pain patients and working with this pain management physician, tell us a little bit more about that transition.
There is truly a sort of an unknowable spectrum of suffering that people can have that most of us never know. If we've been blessed to not have severe chronic pain or really any severe pain at all, I've suffered injuries, but I don't hurt very long. I have a high pain tolerance. And that's not because I have a lot of willpower or I'm better. It's just because that's just how I'm made. Some people suffer injuries so horribly severe, like spinal cord injuries, nerve injuries, that it's like their leg or arm is on fire 24 hours a day. And none of us except those people know what they're suffering through. And I started to see that the way we were treating some of the patients was unfair to them. You know, we had no sympathy. We had no compassion, especially in the emergency room. And when I became the director of an emergency room, I set strict standards on how patients would be treated. Even if you can't give them what they want, you can treat them with decency and respect. And then I took pain management for the primary care physician, which was a course, an in-person course at Harvard, and started taking an interest in pain management itself. So for our clinic, which had multiple providers, I was the kind of the go-to guy for controlled medications. Anyone who was there, if they were on, benzodiazepines for anxiety, if they were on something for pain, I was the one that handled that because my experiences working with the pain specialist and all my extra study had given me more perspective on it than the rest of them had. So we became known for being capable for treating pain, and oncologists would send patients to us, as would pain specialists. Because your pain specialist wants to see you, do a procedure, start you on your medications. It's not really appropriate for them to see you every month. Your family doctor should be willing to do that on a monthly basis. And then you go back and see the pain doctor at whatever schedule they set up. They'll say, let me see them every 6 months, or I'll see them in a year. Sometimes there's nothing more for the specialist to do. And that's what I consider, palliative care, when everything's been done and that's just how they're stuck. And that's mainly the patients we treated. We would not treat patients who had not been seen by a specialist and had not been started on opiates by another doctor. When I say we wouldn't see them, we wouldn't accept them for chronic pain treatment. We would find them another specialist or someone else to. If they came to us and they hadn't been seen by a specialist, we would refer them on to the specialist.
All right. And we're going to talk more about that position a lot of physicians are placed in with the treatment of legitimate pain. in the context of the opioid crisis, and that puts a lot of clinicians in very, very difficult situations. And you talk more about that in your Kevin MD article, The Persecution of Pain Management Doctors. Now, this particular article resonated with my audience, over 4,000 social media shares. Tell us how this article came together.
I had a patient who had suffered an industrial accident 10 years before I met him. He had been on opiates for the pain from that. He had had multiple back surgeries, metal plates and rods in his back. He'd been put on benzodiazepines for spasms and the PTSD that often accompanies some traumatic injury that was bad enough to cause severe chronic pain. He could no longer work in the factory, and he started working as a prison guard, and there was an emergency lockdown, and he was running to get to safety. His right hand was trailing behind him, and it was caught in a sliding steel door, one of those big steel doors, and it crushed his hand and basically pulled off most of one of his fingers. And he went to the emergency room, and his family doctor had just moved out of state. And so he came to see me. He was referred to me by a pain specialist. And so he came to see me from the ER, already on opiates for 10 years for his back. And he was on, I think, 270 morphine dose equivalents when he came to see me. So not the 90 that the CDC recommended that primary care doctors seriously consider before going over. He was already on 3 times that when he came to me for his back, and now his hand's just been crushed, a finger's gone, rotator cuff tear from the traction, and a neck injury.
Mm-hmm.
So you have to decide, this is a legacy patient. He's just suffered an acute injury. It seems common sense that you would have to treat that pain. There's a misperception that people don't die from pain, and that's kind of true, but people don't die from guns either. It's always the bullet that kills them. So people don't die from pain. They die from the stress-related consequences of untreated severe pain. So they knew during the Civil War that people did die from pain, and they had to cut off people's legs without anesthesia, and they had a very limited amount of time to do it, or that person's heart would stop and they would die. And that's what happens. People die from heart attacks, heart failure, strokes, from the stress-related consequences of severe untreated pain. But there's no way to say the pain itself killed them.
So tell us what happened next. So you had this patient come to you. What happened next in the story?
I got him through multiple hand surgeries. He got a bone infection in the hand. We got him through all that. IV antibiotics and all bulb. Got him through the shoulder surgery, another back surgery. We were getting him all lined up. He had one more surgery left, a neck surgery. So he's driving to Plano, Texas from Arkansas. He's driving to Plano, Texas to see a neck surgeon, neck specialist. He's got written instructions from one of the other specialists, the spinal surgeon that had referred him to this neck specialist. He's following the written instructions and trying to drive, and he's weaving. So a car dials 911 and he gets pulled over. So he'd already been driving 4 or 5 hours. He had to get up very early. They asked him about if he had been on any medications, if he had been drinking. He said, no, I haven't been drinking, and I took my medications at 9 p.m. last night. And they want to do a field sobriety test. Well, he told them the only thing he had taken that morning was his Lyrica. Lyrica causes nystagmus. So he's not going to pass a field driving test. Plus, he can't stand on one leg period, much less do his ABCs. His back injuries have caused nerve damage. He can hardly feel his legs. And he explains all this to him. But then they go through his car, find a bunch of bottles of medication, say, oh my God, who put you on all these? And they arrest him because they found a trazodone out of its bottle. A lot of people don't know that if you have a prescription medication of any type, Prozac, and it's out of its bottle and you're outside your home, that's a crime. So if you carry something in the Monday, Tuesday, Wednesday boxes, that's actually a federal crime. You can be prosecuted for that, and usually a state crime also. So they booked him and put him in jail. And as he was being processed in jail, they drew blood, and he told them, I have these severe problems. Am I going to be able to see my surgeon? No, you're not. Will you call my doctor? No, we won't. Will I get my medications on time? He was told, yes, you will. So he was arrested at 11 a.m. Around 2:30 p.m. He's telling them, hey, I took it last night. I'm really starting to feel bad. They refused to give him his medications. He started beating on the cell walls with his bare fists. And you can hear it on the camera. We have the video. You can hear the pounding. And they go tell him to be quiet, but they still don't give him his medications. And they tell him, we don't want someone to overdose in here, so we're not going to give you anything. 5:30 p.m., he gets quiet. 5:30, they go around to give food, and he's lying on his bed, and he's drooling, moaning, and breathing strangely. One of the guards comes out and makes a sign like this to the others and says, he's out. They don't call for help. They do nothing. 6 p.m. guards change over. 6:30 p.m. the new guards get around to him. He's in the exact same state, but they recognize a medical emergency. So they call for help. The EMTs arrive and ask, what medicines is he on? They don't list all the medicines he's on.
Mm-hmm.
They say he's having an overdose from opiates. So he gets Narcan and he's shipped out. Well, he had been on diazepam, 40 milligrams a day for a decade. I had just cut him down to 30 milligrams a day 30 days before this because I wanted to reduce his exposure to benzodiazepines and opiates. So he was already on a reduced dose. And the EMTs were not told that his benzodiazepines had been withheld. If they had known he was having seizures from benzodiazepine withdrawals, they could have given him a shot of Ativan or diazepam and saved his life. But they didn't know that. They weren't told that. So they ship him to the ER. By the time the ER doctor gets a look at him and is trying to work him up and everything, his heart fails. So autopsy the next day finds an 80% blockage of the left anterior descending coronary artery. And the coroner says that he died from natural causes, from heart failure, but he can't rule out a contribution from either opiate overdose or withdrawal, because the guy's, chronic levels, his chronic blood levels are going to be high, higher than normal. So when they run the tox screens are designed for people not taking any opiates. So they'll come back and say toxic when it's, above. It takes about 1,600 nanograms per milliliter for an opiate naive person to die from oxycodone. His were 990 when he came in, 660 when he died. So, and of course, a person on chronic opiate medications, their levels truly can be anywhere. There are people on huge amounts of medication that seem insane till you realize that's what it takes for them. All right. So after his death, the jailers call his family and say, your loved one died of an overdose. His doctor killed him. They called the DEA, and I ended up getting prosecuted for his death. They tried to give me life in prison for that man's death. Now, state authorities would not be able to prosecute you if a coroner had said natural causes, but there is no law that a federal prosecutor actually, must follow. There's no one to force them to. If the state does something wrong, you can go to the federal authorities, and they're pretty good about policing the state authorities. But who do you go to police federal authorities if they're on a bender like they are right now? The opiate crisis has become an opiate panic. I see these articles about how acupuncture is probably going to be good enough after hip surgery. I would be very interested in seeing the results of that study. I find that now, do those things help? Absolutely. Are they going to make the pain tolerable? I doubt it very seriously.
Talk more about the professional ramifications of this case. You mentioned that the DEA came after you, prosecuted you. Tell us more about that experience.
It turns out that if you're lucky enough to be a drug dealer, they have to prove that whatever you sold caused the death of the person who died. So if someone's dealing heroin and someone dies while on heroin and Xanax, they won't be able to prove that it was the heroin that killed them, not the heroin and Xanax, or the heroin and alcohol or something like that. But physicians aren't that lucky. The law reads that if the medication you prescribe contributed to their death, and that is a standard where you're having to prove a negative. You have to prove that the medication you prescribe did not contribute to their death, and that's impossible. If an elderly person on opiates for 30 years dies in their sleep, you can't prove that opiate medication did not suppress their respirations enough to their death that night. So any doctor treating pain who has a patient die for any reason can be prosecuted. They're usually not, but they can be. So you'll see these doctors getting 20 years, sometimes life in prison. They were treating pain, or they had prescribed something for anxiety and a person had drank alcohol with it and died. Well, the law just says if your medication contributed. So, you're gone. Even people with fentanyl in their system and a hydrocodone. If you prescribe the hydrocodone, they can still lock you up as if you killed that person.
So tell me about the outcome of this prosecution. What happened next?
Because they had they claimed in the charging documents that I had intentionally prescribed something I knew the patient didn't need. That made it impossible for me to plead guilty. Now, I understand that no one takes it to trial in federal court because they think they will win. There's no winning. Your life's already destroyed long before you get there, and their chance of being acquitted is 0.04%. So 99.6% of the time they win. You take it to trial in federal court if you're not willing to lie and say you're guilty when you're actually innocent. And I was innocent of the crime, as in I firmly believe every prescription I wrote was in the best interest of my patient. And that's why I wrote it. And I wasn't going to go in court and say otherwise. So I risked life in prison. And luckily, the jury was able to, the medical examiner came and testified, the coroner testified that my medications had nothing to do with his death. And I was found not responsible for his death, but they did convict me for treating him at all. And the prosecution is trying to give me extra time for that first prescription I wrote. So a man comes to me on 270 morphine dose equivalents of opiate medication from his back injuries with a new hand injury, shoulder injury, and neck injury. And it is a crime to write him a single medication, right? As if I'm supposed to just cut him off abruptly, which would have immediately killed him, of course. And not only that, but they're also trying to sentence me for the medications that they did not bring to the jury. So if they prosecute you for an oxycodone prescription and you get found guilty, now they can add in the benzodiazepines and anything else that you had prescribed over that entire period of treatment. The jury didn't find that, but they found one. So if you get convicted of anything, it lets them throw in everything. And they are still arguing that I should get extra time for his death. The fact that the jury found me not responsible for his death does not necessarily protect me from the judge feeling like I deserve extra time for that.
So tell us the impact of this case that it had on you, on your practice, and
I was the
your
last
license.
man standing in this area our clinic, willing to treat people, to be the PCP for people with severe chronic pain. So that left, hundreds of patients scrambling, trying to find treatment, treated horribly in the emergency rooms, and every other physician will be terrified to treat them. If you know someone came from a clinic that was shut down, you're terrified. You're afraid you'll be targeted. So that left the patients in a terrible situation. Of course, it's absorbed everything I had put back for retirement. That, you lose the medical board looked at these same patients, by the way, prior to my indictment, and they did an emergency order of suspension at first, looked at the patient records and removed the suspension. And law enforcement people went on the news saying they're taking it too easy on doctors. And that's when I was indicted. After the medical board had looked at the same patients and returned me to practice. And medical boards are not a walk in the park. I don't know about other states, but Arkansas will come down on you with both feet just for, they will absolutely shut you down until they are satisfied that it's safe to let you practice. So they're not, they don't go easy on people in this state. And I thought that would help also. But in the end, there's nothing you can take into court with you. I have a textbook right here about this thick, the Principles and Practice of Pain Medicine. It's not allowed in the courtroom. Your CME is not allowed. You can bring an expert and they can argue, and he or she can argue with the government's expert. And these government experts are selected from around the country, and they have extreme opinions. The one that testified in my case said the MRIs were not objective. He told that to the jury. He told them that a silent paging system I had, so we didn't have to yell out patient names, was not the usual practice of medicine. And the jury doesn't know. We asked too much of them. We have 12 people without medical education coming off the street. They don't even understand the word you're saying. You're trying to talk to them about, endorphins and dynorphin and enkephalin and the mu opiate receptor. You may as well be speaking Greek. They have no idea what you're talking about. But, it takes 4 years of dedicated, intensive training and study before you begin to have a concept of who needs which medication. Pharmacists aren't allowed to do that. Nurses aren't allowed to do that. Only physicians are allowed to do that. Yet a federal prosecutor or a DEA agent will think that they can, in just a very short amount of time, know better who needs what. And I'm not saying doctors don't sometimes do things wrong. If you're trading prescriptions for sex or selling them out the back, without ever seeing a patient, okay, do your time. But that's not the case in a lot of these prosecutions. And over the last 3.5 years, since all this started, I have been reviewing cases of physician prosecutions, and about half of them I say, yes, that's reasonable. And the other half I say, why? Dr. William Bauer out of Sandusky, Ohio. Ridiculous to prosecute that man. 50 years as a neurologist treating pain. He didn't do anything that is technically illegal, that is a crime. Yet the man's still in prison at the age of 83. They put that man in prison. And you have to decide when they come after you. Dr. Jay Joshi wrote a beautiful book, The Burden of Pain. You have to decide when they come after you. Do I plead guilty and take a lighter sentence knowing I'm not guilty? Or do I take it to trial knowing that my life will essentially be over, that they will punish me for taking it to trial, and that I will probably get some ridiculous sentence? And that's a tough call to make.
Now, for those physicians who prescribe opioids and listening to your story in this podcast, tell us, what kind of lessons have you learned that you could share with them?
I would say the first thing that you need to do, if you're treating pain and you're prescribing opiates, if you get the little monthly things saying where you are, some doctors don't prescribe more than 5 milligrams of oxycodone 3 times a day. That's what the specialist or expert who came to testify in my case, that's all he said he treated. Well, I had 85 patients with cancer I was treating. So they were on a lot more than that. I mean, one patch is 200 morphine dose equivalents of fentanyl.
Mm-hmm.
So I would say get a law practice that specializes in healthcare law to walk through your practice and see if there is anything where you're vulnerable, because there's things that doctors don't notice or don't realize. And also get a second opinion on everything. There were 3 patients I was prosecuted for. On one, I was acquitted, and that's because I had our own psychologist, but when he started having suicidal ideation, I sent him to an outside psychologist and said, do I continue his medications or do I not? And no one wants to tell you anything. No one wants to actually give you an answer. Finally, he did. He said, continue pain medications. 3 words that kept me from being convicted for that patient, because the jury saw that and said, well, okay, another doctor agreed. But as long as it's just you, that's not good enough. Get back up and get a walkthrough. Have somebody walk through.
And my final question, Joseph, tell us some of your take-home messages that you want to leave with the Kevin MD audience.
This is a phase that we will hopefully pass through. Politicians have decided that the opiate crisis needs something done. 90% of deaths are from fentanyl being smuggled across the border, but they've given up on trying to help with that. And now we've got xylazine and all these other things. So don't expect this to go away. Tracking down a drug dealer in the deserts of Arizona or a cartel member in Colombia, it's extremely hard. Rounding up a doctor, scanning 1,000 patient interactions and finding one that went bad and saying, this one we're going to roast him for, that's easy. That's a walk in the park. They know it's all laid out. There's no doubt you prescribed it and something bad happened and someone must pay. That is a very, very powerful thing to put in front of a jury who does not understand the practice of medicine.
Joseph, thank you so much for sharing your story, time, and insight. And thanks again for coming on the show.
Thank you, Kevin. I really appreciate it.